Great, thank you. Well, welcome everyone, to Patient Safety Awareness Week, or welcome back if you've been part of our series this week. Sometime this week, we had two really great webinars over the past 2 days, and Riley can link you to those recordings if you weren't able to make it. On Monday, we talked about AI and quality and safety of AI. And then yesterday, we really talked about human-centered design and its place in workflow analysis and how to make the medication safety, enhanced medication safety by controlling for alerts and making those more effective and efficient for staff and end users. I'll be your moderator for today's webinar. A little bit of background on Sinensis. For those that are new to knowing us, our mission is to maximize the capacity of high-risk organizations to achieve safer outcomes. Today's session is one that I'm really looking forward to. It's entitled Structuring for Safer Outcomes, Building an Effective Patient Safety Program. The session will explore how a strong patient safety structure grounded in frontline engagement, clear leadership support, and meaningful data can reduce preventable harm and strengthen organizational reliability. It's a real pleasure for me to have my dear friend and patient safety colleague, Daniel Baily, with us today. As some of you may know, if you've been along the journey with us, Daniel's started his journey in patient safety with Sinensis many years back. And it's been incredible to watch the impact he and his team have made since founding Batera just about over 10 years ago. So he's become a respected leader in patient safety and healthcare quality with a deep passion for empowering frontline teams to use meaningful data to drive improvement across complex systems. Daniel's work spans organizations around the world. I've been on many of those trips with him and helping executive teams, improvement leaders, and frontline staff strengthen safety culture, elevate system reliability, and address some of really the toughest challenges out there in healthcare. His commitment to creating data-informed, people-centered solutions has made a lasting impact on how healthcare organizations measure, understand, and improve patient safety, and also patient safety culture. So a quick reminder, today's session will be recorded, and you can submit questions or comments anytime through the Q&A feature. We'll have that open throughout. The chat will be closed just during the presentation, then reopened soon after. But feel free to use the Q&A feature on your console to go ahead and put in those questions as they pop up during Daniel's presentation, or comments you just want to add and maybe reinforce some points. So with that, let me turn it over to my good friend Daniel, and you can take it from there, Daniel.
Thank you, Steve, and good afternoon, everyone. It's such a pleasure to be speaking with you all about one of my favorite topics, which is not just patient safety, but the structures that go into place to ensure highly reliable outcomes for our patients. And got a lot of affection and history for the Sinensis team. So for those of you that I don't know that are on from Sinensis, you all do such wonderful work. And much of this today will probably seem very much a part of what you're doing on a day-to-day basis. But I hope over the course of the next half an hour or so, I can put together some of the top down and bottom up of what this looks like in practice and where some of our intentions to have a highly reliable facility, a highly reliable hospital or healthcare system, where they start to fall apart, where the cracks in this model start to happen. So being with a focus on patient safety, I just wanted to share one piece of information that I read this week, coming out of the Healthgrade's recent report on patient safety, and this just paints such a clear picture to me of what is possible now. So we talk about zero harm. We talk about reducing massive amounts of harm and waste and cost across our healthcare system. Sometimes for some of our operational leaders or executives of healthcare organizations, that can all seem very, very distant. But something like this just seems so feasible and so possible. the health grades, sorry, I found this on Becker's, the link is there, but what the folks at Health Grades did is they took the top patient safety performers from their data set from a 2-year period, 22 through 24, and said, what would a number of harm events look like if all of our organizations or all of the organizations across the US performed it the same way that these top performers are able to perform? So basically, if everyone was at the same level rather than the stratification across what we normally see. What that meant directly is 100,000 plus fewer patient safety events, many of those with significant harm, would be saved over a 2-year period of time in our country, just if everyone achieved what other organizations are already achieving today. To give you a sense, 100,000 harm events, if we were to say what's a city where that would impact every single household directly, we're talking about 100,000 households. That's Raleigh, North Carolina. That's Anchorage, Alaska. That's Orlando, Florida, maybe. So significant amounts of harm. Of course, we know that happens systematically across our healthcare system, but this is super, super preventable harm. To give a new term to it, this shouldn't be happening because it wouldn't be happening at other organizations that had more robust structures around ensuring high reliability. You all know some of the top level big stats on the amount of harm and waste that happens across our system. But what I want to propose to you today is that there's a real gap between the intentions that we have and our colleagues on the executive teams have and what actually happens day to day in situ in the frontline clinical teams that are putting hands on patients. There's a real gap that breaks down there. We're pretty good overall about having some intentional structure. We do that because of regulations. We do that because of organizational policy, but we often fail to achieve, obviously, the aims that we have for a highly reliable system. And so I want to look at the two factors at play here. How we set up structures and lead organizations from a top-down perspective, it's critical. But how the real work of improving patient care, whether that's improving quality, reducing harm, how that happens from kind of a bottoms-up perspective. So I'm just proposing a little thing here. This is not a researched model, but this is just my perspective, if you will, on some of the key responsibilities and why they need to go together, how this is really the full picture of a patient safety culture. Of course, from a top-down perspective, we've got to have clear direction. We've got to have a commitment amongst our executives towards zero harm. We have to have patient safety plans. We've got to be thinking from a senior leadership perspective around resolving systematic issues, things that are not based on one individual department. Perhaps we have staffing challenges or technology challenges, errors that are occurring or near misses that we're catching because of our EMR or order provider entry system. These are systematic things that no one clinical team is going to be able to solve. Those things fall to us as the quality and safety leaders and as the executive team and board members to respond systematically. But a huge component of what our structures need to do is to really empower frontline teams, local teams, to solve the day-to-day issues, the day-to-day variability that ends up causing a harm or the risk of harm for our patients. So that's probably something that all feels very familiar and very of course in terms of top-down. But from a bottom-up perspective, this is where I think most of us say we could have some significant room to improve. How systematically are we actually responding in frontline clinical teams to issues that are being elevated? If we capture a near miss, is that driving some type of remediation, some type of action? If we have results from a patient safety culture survey, are we automatically taking local action to address some of the lower perceptions about our culture of safety? How quickly are we able to escalate needs for additional support and resources and get direct support, not just generalized support? Our leaders care about safety, but direct support. We need to change a workflow, change a technology, change a provider group, whatever the case is. And ultimately, as much data that we have in quality and safety, I think we underutilize to a massive degree the eyes of the frontline staff. And that could be through feedback or through just listening and having robust systems to using the perspective that they have on what could go wrong tomorrow, what almost went wrong today. We have this massive intelligence network, if you will, at the front line to identify risks to safety for our patients and our staff. And most of the time, if we're honest with ourselves, there's really no systematic mechanisms for capturing those things and responding to them. To try to give a little bit of an analogy here, I love music. I love playing music, writing music. And so I was trying to think, what's a good picture, word picture that would describe this need for really robust structure and then also this organic life that lives within it. I don't know how many of you all are fans of jazz. Jazz is one of my favorite types of music, genre of music. And I think it's a perfect picture of what we're describing here. You might have heard jazz, been walking down the streets of New Orleans, or somebody on a trumpet or a piano just kind of riffing, and you might think, well, it's just this really organic modality of music. But the reality behind true jazz is that it's one of the most structured forms of music. And that basis, that structure gives way to a lot of improvisation, a lot of spontaneous, wonderful things that happen. So the key is always set. The jazz band always has a key. There's actually a chord progression that's set. So they're actually playing a kind of never-ending progression. The time signature, of course, is there. There's different forms to the music. And then on that basis of structure, the individual musicians have a lot of freedom to make incredible music through direct improvisation or playing off one another. We can think about what that would look like in a patient safety context of just organically different teams, emergency department and staff working on improvement projects together, fixing processes together, a lot of call and response. And ultimately, we end up with a really incredible in this case, set of music, but I would say to apply this back to safety, real opportunity here to structure our safety programs in a way that creates a jazz-like outcome, if you will. All right, so let's dive into each side here, the top down. I mentioned that you're probably pretty familiar with what this looks like in practice from a top down perspective. Although if we take a moment to think, I know many of you are quality and safety leaders. I don't mean to say that top down starts at quality and safety. For those of you working with organizations or in organizations that have board members, that's where it starts. For those of you working in maybe MTFs that may not have a board group, but may have a clear executive structure, that's where the top down starts. Safety and quality, we're experts in this, we're guides in this, but the direction ultimately, the desire to respond to systematic issues, the desire to truly support local teams, that has to come from these operational executives and or board members. We know as a quality and safety leader, there are never enough hours in the day, and there's never enough hours in the day to support all the frontline needs that exist and empower them. We do that through programming, we do training, we review events as they come into our event reporting system. We do FMEAs or RCAs, and that is empowering the local teams. But fundamentally, we need the operational structure to really be driving this. And we're there as a guide, supporting them, giving guidance on what some of our targets should be, what some of our gaps are. There's different ways of looking at the top down, but I'll focus on one really briefly. There's a new mandate, and this won't apply, I don't believe, if you're in the military healthcare system, but it's a good thing to look at either way. There's a new mandate for this from the Centers of Medicare and Medicaid Services, or CMS, that went live in 2025, called the Patient Safety Structural Measure. A bunch of different domains and elements to what that means. But I want to just look at the components of the leadership domain within the patient safety structural measure to give a really practical sense of what top-down structuring looks like according to CMS. This was built off of decades of different research and best practices, the National Patient Safety Action Plan, a lot of great thinking was bubbled up into this one regulation, if you will. And just look at some of the elements here for senior governing boards to be spending 20% of their time. I'd argue strongly that by the spirit of this regulation, most boards are far from this, spending 20% of their time at least on patient safety, on the quality of care. That senior governing board, that team is the one reviewing safety metrics, setting performance goals, ensuring that executives, operational executives, are even being compensated based on the overall safety and quality performance. That leaders would be the ones really drafting and implementing a patient safety plan. That might seem foreign to some of you. Wait, that's my job. No, again, you're the guide. You're the expert in that. But ultimately, the operational executive structure should be involved with setting targets for safety improvement initiatives with your guidance and your insights, monitoring metrics, asking questions, seeing why or why not some of these programs are successful. So top down, pretty clear. We probably have some opportunities for all of us when it comes to moving some of the burden here onto our senior governing structure or executive team. And these might be some good ways, both the patient safety structural measure, or there's a 2013 article from Dr. Mark Chasson. This will be in the slides. We won't go through them in detail today, of what it would look like over time as you progress towards high reliability for the senior leadership structure to truly own patient safety and quality outcomes. And so maybe some good fodder for discussions with your executive teams. So that's some of the top down. But what about the bottom up perspective? Well, in a real sense, this is where most of the magic happens. The structure is there to support what's happening in a really organic way in little bits all across the organization. And I would guess for most of you, this is where most things fall apart. Of course, we know that our clinical team members are taking actions every single day to prevent harm or to catch harm before, catch errors or catch risks before they get to the patients. But then there's a lot of these broad quote unquote programs, huddles, safety culture assessments, lean daily management projects or local PDSAs, comment boxes, approaches to surface different challenges. A lot of those programs, if you will, that are meant to enable frontline teams to continuously improve safety and quality, a lot of times those structures are what are there perhaps by policy, perhaps because we've rolled something out in 2021 and did a training on it. But in actual practice, day to day, this is probably where work as imagined versus work as done has the biggest delta or the biggest gap between the two. So a couple questions to reflect on. Where are your CLAPSs being reduced right now? Is that in the boardroom or is that in the ICU? It's a little bit of a trick question. The answer ultimately is both, based on what we've been talking about. The board, the executive team, has a responsibility to make the investments, ensure staff in the ICU are equipped and understanding how to do systematic improvements and best practice methodology. But of course, the day-to-day where the rubber really meets the road is happening in the ICU. Interestingly, it's not happening in a clinic on site, right? So one size fits all is not going to work here. We really need the ICU team specifically to be equipped and looking at data in order to reduce collapsing. Same thing would apply, right? If we've got a patient safety culture assessment, how do we improve the culture or the perceptions of patient safety culture in the emergency department? Is that happening in the boardroom or happening in the emergency department? I would argue for most organizations, the boardroom or the leadership room is where all of the efforts to improve safety culture are happening. We get our results from a survey where we come up with a response plan. We might try to roll out some of the results, but any kind of action plan is really being done at a high level Really, again, one size fits all. Are we empowering the manager of our ED and the team within the ED to really dive into their data themselves, to have problem solving discussions, to work directly across nurses and physicians to resolve some of the cultural issues that are local in their microculture? So, of course, both of these are trick questions. They're both but I do think it highlights the importance of our structures getting to the bedside, getting to the support of bottoms up improvement. So let's spend the rest of our time talking about where this top down directionality, goals, accountability, empowerment meets this day-to-day kind of the organic bottoms up improvement efforts. So one big term for this could be safety culture. And there's certain elements that we need there. Psychological safety, we've got to have the ability to speak up freely. That starts with top down. We've got to make it very clear, and hopefully most of you have, that reporting is a safe thing to do, that we want to hear as much as we can about things that are going on. But of course, there's staff accountability and engaging in those things as well. Feedback loops is probably where we have the biggest opportunity, as I mentioned earlier, to collect and to aggregate and respond to particular or themes. AI is super helpful here, are from the intelligence of our frontline staff members, be it anonymous or directly. There's some real opportunity. But from a leadership perspective, we fail day in and day out to totally close the loop on the things that we are responding to. So we're getting feedback, we're responding to it. What usually gets left off is making sure that the staff know that we've just solved this problem for them. I'm going to come back to that in a moment. And just like in a just culture here, there's definitely shared accountability across the board. Leaders do need to be owning safety outcomes. Your operational executives need to be owning patient safety outcomes. But at the same time, our local leaders, those in situ, in the frontline teams, they need to be the ones that are held accountable to following up on all of these improvement projects, daily huddles, things of that nature. So if we're to put some of these tools, if you will, together and look at the tip of the iceberg, to switch metaphors here, with what's happening on a day-to-day basis in our frontline teams. Of course, we've got this strategy, the very visible thing, the policy, this training, the tech, the goals, the improvement plans. That's really the tip of the iceberg. That's the structure that's helping with all of the innovation, with all of the melodies happening across our organization. But the operational reality is where the local teams are doing their huddling, their event reporting, their department or unit-based meetings. And there's one thing here that I think if you're sitting back and saying, hey, we have a gap. We have a gap between the structure or leaders and what's happening day to day. The best tool here that I could point you to would be robust and meaningful rounding. So you might be doing rounding, and it might be glad handing, or it might be just being visible, right? And there's an element to it that's great. But a true information system supported, diligent, consistent rounding program can help solve this divide between the tip of the iceberg and everything under the water. So let me focus on that for just a moment here. On leadership rounds. I think this is where what we talk about in the boardroom, what we talk about in the executive room, about how committed we are to safety, the great things that we're doing from a safety perspective. This is where we really get to see what that looks like in practice. There's really no reason to have any PowerPoints whatsoever that talk about our error prevention tools if they're not being spoken during clinical practice at the bedside, right? So of course we put them on PowerPoints and train our leaders, but that gap between reviewing our error prevention tool training for onboarding of all new clinical staff, often that's the level that leaders are interacting with, senior leaders, and they might not have any idea that some of these error prevention tools, whether or not they're being used during a trauma case or during a procedure in the OR. There's a few different elements or lenses to bring here. Of course, from an HRO perspective, leadership rounds is a phenomenal way of thinking about sensitivity to operations, a deference to expertise. We can set a goal for zero classy, and we can say that adopting a best practice bundle that was done at another facility will work. But really, we need our physicians and our nurses in our setting to help us understand what it may take to adapt those external best practices to our local setting. It also really helps to not simplify. It can be very easy as a leader to see a red flag, find a best practice, connect the two, send somebody off, say be fruitful and multiply. But when we're there in the unit, hearing from nurses, doctors, local leaders, it can really help us to say, hey, there are actually a few different vectors here, like our staffing and our EMR, that make it very difficult to just adopt this best practice bundle. So a lot of things from a practical perspective, this does well if we have it in a robust way with meaningful data. So not just showing up and saying, hey, how's it going? Anything I can do, but having conversations directly about hey, how was the huddle this morning? Or, hey, I saw we had a near miss yesterday. Any ideas on how we can prevent that in the future? Or I'm aware of the PDSA that you all have been working on and how we've been really struggling to hit our project goal with door to dock times. And so can you help me understand what barriers are there? Provides a really powerful way. It's kind of culture in practice, these brief interactions to remove barriers rapidly, to continue to build a culture of safety and psychological safety. And as I mentioned before, a fantastic opportunity to start to close the loop in real time. We're not waiting for an every 18-month survey here. We're saying, hey, I was here on Monday. I heard that this particular piece of equipment or process is a barrier. I wanted to let you know I had these conversations and here's the next steps. Creates a much more rapid cycle improvement and closing the loop there. So to try to land the plane here, I think there's some real opportunities if we just think in, again, top down, bottom up. Where are we strong? Where are we weak? And most importantly, how do those two interact? This, I think, is why many of our efforts to improve safety, we might have the program, it might have been around since 2018. But why is it not producing the outcomes that we're hoping that it would produce? There could be top-down problems with that. We see these things as projects or as the role of quality and safety and not as the role of all leaders. We could have particular safety events that cause some structure. I can guarantee you that third bullet on the left there, we're getting more data than we're acting on. And the fourth bullet, we're acting on more things than we're telling staff that we're acting on. And then, of course, all of our safety programs, they tend to start with big bangs of communication, branding, excitement, a CEO video, a new training, and very often as the communication tails off, staff feel like these things are just kind of blips on the radar, flash in the pan, and they disappear. So to think about, hey, how can we implement top down, bottom up in a way that prevents this stalling from occurring? A number of different things there, but ultimately, we again focus on, hey, we've got to do a much better job of sharing the wins that we have and building that psychological safety between leaders and frontline staff, closing the loop far more diligently. So if you're not doing rounding, you got to start it. It's one of the requirements in the patient safety structural measure. If you are a standard healthcare facility, I'm sure that there's much of this already being done in the military healthcare system, but either way, undoubtedly opportunities to enhance your rounding with information systems, more real meaty discussions and less just visibility. And I would encourage you on this to find a couple elements here. You don't have to use any of these slides or any of these examples, but how can you ensure as a quality and safety leader that you're helping your executive teams, your board members to understand their role, how critical it is, and what the gap between their top-down plans and structures may be between the day-to-day improvement that's happening across dozens, if not hundreds, of frontline clinical teams within your organization. So that's the big picture there. I know this was a pretty quick flyby of just a way of thinking and hopefully a way of assessing how your organization is doing with these two critical elements here. We've got to be intentional here. We've got to refine and build solid structures. But if we do that without the sensitivity to operation, we're preventing any of those melodies happening at the front line, which are critical for reducing harm that's specific to that clinical team. Overall, this is a long-winded way of talking about a true culture of safety or a true high reliability organization that has all of these features functioning and functioning in meaningful ways, not just that we do a huddle, but that the huddle is identifying opportunities to reduce risk today. Not that we just do a round, but that rounding is truly building psychological safety and removing barriers. Not that just we analyze safety culture survey results, but that we use them for meaningful improvement discussions and action plans. All of those things has to do with the connection between top down and bottom up. So I think we're going to move to a time of Q&A. So happy to dive into detail. I know this was a pretty high level approach here, but love these types of conversations and always interested in talking more about them. But I'll turn it over to you, Steve.
Well, thanks, Daniel. That was awesome. I'm going to put my little applause right away in there. Great session and grounding us in top down, bottom up. We kind of talk about it, I think, a lot and thinking about that it's important, but how do we actually operationalize it? And I think you've given us some real ways we can reoperationalize if we haven't been able to get through there. A couple of I put in one question around that because it really got me thinking a little bit about some of the challenges. But also I see one of our good friends here, Gwen Sherwood, is in the meeting today. So she said, love to look at top down, bottom up. Nurses often feel the need for a bottom-up approach. Can you offer ideas on how to break through barriers, whether persistence, being true to values, or getting attention at the top? So just some ways that, they're sort of like, you're definitely trying to make it happen, from the bottom-up side, but ways that they can kind of break through to help get that support, I think, from the top down as well.
Yeah, it's a great question. It's a sad question. If you think about if you had an organization and your aim was to achieve quality, safe outcomes, and then you had staff organically attempting to do that, and they're just not even on your radar. It's a sign of a pretty big gap, and it's I think we see it a lot in nursing structures where ultimately all of our frontline staff they truly do care about these things, and if we give them the time to think and work on them, they're going to do this naturally. So in some ways, our structure is there to give folks the time and the space to do the very thing that they want to do, which is improving the work. In terms of getting the attention of our leaders, very often leaders respond to the squeakiest wheel. That might be financials, that might be a market perception. And frankly, very often our executive leaders who think about our CFO, we think about maybe our COO, they feel very confident in executive level discussions, high level views of data, organizational strategy, and they actually feel far less comfortable in the types of things that a nursing team would be elevating, such as a particular clinical process or program. A quick anecdote on that, I was observing some rounds a year ago with a chief financial officer. And as we walked into the emergency department together, he leaned over and whispered to me, "This is the worst thing that I do in my job." And so I asked him about it later. Why do you feel that way? And he said, because I'm a fish out of water. I have no idea what they're talking about. I have no understanding of the issues. I know that they need help, and there's just nothing I can do to help them. And so I never got into accounting in order to solve, issues between doctors and nurses in trauma care. And so a couple of just takeaways there. I do think that in nursing specifically, some of the organizational, like nursing best practices around PI, nursing quality, unit-based councils, nursing governance type of things can help senior leaders understand, like, hey, here's a structure here, and here is almost more of a formal way in which things are being kicked up. Like, hey, across our shared governance approach, our three biggest goals for this coming year are CLAPSI reduction, using error prevention tools with our physicians and getting their alignment. And here's where, go ahead and articulate from a senior leadership perspective, here's what we need you all to help us with. Obviously, it'd be great to have an executive champion on any of those efforts, and so maybe finding that one person that would help there. Another idea there. Often leaders are not great, as we've talked a lot about today, at the one-on-one, hey, here's one individual who has this one problem. They're thinking about the horizon and what's happening in 5 years. They're often not thinking about the windshield problem today. And so sometimes those anecdotes just don't really help, right? They're thinking, hey, how do we survive 5 years from now? Not how do I fix Janet's problem this morning? So aggregating some of that, right? Having nurses provide, hey, even a homegrown survey on, hey, we had 150 nurses, who gave their input to quality and safety improvements. And we asked them specifically about how leaders can help more. And they said these three things. Help us have conversations with the docs. Help us get the data that we need to track these improvements options. So just a couple of different ways, kind of a structural way and a data way. I hate that question has to be asked, but it's a great question, and it's reality.
Yeah, thinking about like with Gwen's work with the CUSIN competencies, quality, safety, education, nursing, right? So nurses for a while have been getting, they're some of the best at patient safety, right? They're at the point of care where care occurs, so that, and their ability to know how to make things safer is relevant, and they are the other side of this is with your senior leaders thinking about the fact that they turn over a lot, and what are you seeing as kind of best practice on the other side of the equation, coming from the top down side, about how they're able to educate leaders and sort of keep a culture on the pathway that they've taken to improve. Since you've probably worked with some organizations over the successor side, where you've seen CEOs change over time. You've worked with those organizations long term on a long journey of improving their culture of safety. Anything that you'd share that you've seen with those long time relationships with those high performing organizations on safety culture?
Yeah, absolutely. That's a great question, Steve. And the reality is, for someone coming into a new role at the executive level, championing quality and safety is the easiest way to get staff buy-in, staff trust, to get the organization behind you, if you will. It baffles my mind that so many leaders do. They're thinking about what they're responsible for, and unfortunately, as we talked about in the maturing progression towards HRO, oftentimes they're responsible for operational performance, but not safety and quality. So if you think about it from their shoes, the metrics that keep them in their job or give them an opportunity to get another executive level job are operational metrics. They're financial metrics, operational metrics. And so very often they just don't look at the safety and quality as much. You're never, even if you give pay raises to all of your staff, you're never going to have their trust, right? That pay raise will help for a few months. Excuse me. But if you spend the time to really understand what's concerning staff, which is the quality of the care. What's the output of what we're doing? Is it safe? Is it reliable? Is it good? Are patients satisfied, or family members taken care of? If that becomes your banner, then it's amazing how the other operational things will just fall into place. Recently, it's a rural healthcare example, but recently know of a turnover for a rural hospital in Florida with a CEO coming off of the board into the CEO position. I'm tying this to this presentation today. The very first thing that she did was an immense amount of rounding. And with the rounding, she didn't want to come in and say, hey, I've looked at the national databases, I've looked at the benchmarks, I'm going to set a direction here. Her very first question was internal. What are you all working on now? How do we make those efforts more robust? Tell me the goals that you have, and I'll set those as my first goals for quality and safety. They've seen a massive operational turnaround, financial turnaround, staff engagement turnaround, patient satisfaction turnaround. All of that has happened. But the way that she drove that was to really, it's fundamentally pretty simple here, right? What are staff most concerned about in the quality of the care that they're providing? And how do I empower them to solve those challenges faster? That's listening. That's a culture of safety. Yeah, I think if I were to move into, or if any of you are, from an operational leader perspective or thinking about moving into that, I'll tell you that the easiest button I would know how to do, get focused on quality and safety issues that staff are reporting or seeing. Everything else will fall into play.
I have another, this is maybe a comment and then you can, add to it, which is I think you talk about how culture is so local, right? Even within different areas of, say, a hospital or clinic, right? So, and I also really was honed in on what you said about structure. So can you, are those in tension with each other from the top down to the bottom up, which is the top down providing the structure, bottom up really defining the tailoring and the the fit to purpose side. I mean, can you comment on that a little bit? Because sometimes when we see structure coming from a top down perspective, it's almost similar to like standardization, something that a workflow that may work in the ED may not work in the ICU or on the floor. So I just wonder if there's like some tension between structural, since we're going to these structural measures and structure is part of the conversation today.
Yeah, I think that there is definitely tension, and where structure should stop short, in most cases, not in all cases, it should stop short of the specificity of every individual action that must be taken. And so to give a meaningful example of that, to point back to patient safety culture surveying, although PI or anything could fit here. When we look at a set of feedback data like patient safety culture surveys, and we provide the structure all the way down to the bullet points of the action plan, here's what we're going to do line by line. Our local managers are going to share the results of the survey, and they're going to work on improving handoffs, and they're going to do that by adopting this new iPass tool that we tried and failed to implement in the past. And everything is just totally programmatic. There's no ability for kind of innovation or improvisation. That's where our structure goes too far. And what I would argue is our structure should get to the point where we're telling a clinic or a unit manager, we've provided the tools for you here. Here's how you're going to get your data. Here's how you're going to understand what it means. And here's what we're asking you to do. We know we need to take action against this feedback, but the action that you're going to take may look different. And so here's perhaps even a couple starting points or some exemplars or some best practices. But what we're asking you to do as a local leader is to work with your team on what the biggest priorities are, because handoffs may not be the biggest priority for the 9 to 5 on-site clinic. They're not handing patients off. And I think that's where we lose a lot of the power of our structure, is when we're so programmatic that we don't allow for any innovation. But if we stop short and say, find the biggest opportunity, now we have that 9 to 5 clinic working on patient follow-up, and getting our follow-up scheduled, because that's the biggest issue. And we've missed a piece of information from the docs that would enable us to do this more effectively. And so they're solving something, improvising within the structure we have. Final thing I'll say there is this is difficult. I think you're probably all sitting there thinking like this is a lot easier said than done. It absolutely is. For our structure to work with innovation or improvisation at the local level, we have to have information systems. We have to know, are those leaders doing what are those leaders doing? Are they doing the things that, are they following up on the things that they've said they need to? It doesn't have to be overly complex, but we have to have some kind of visibility into what that is to remove barriers, to hold those leaders accountable. Not every local leader should be in the role that they're in, just like not every executive or board member should be in the role that they're in. And so that accountability has to be based on something observable, visible, which would be an information system on what we're actually doing. So definitely some tension between the two, and getting that balance right might be different for each organization. But I think it's a journey well worth taking.
Well, thank you, Daniel. I know we're a little over time, but I wanted to slip that one piece in since we were talking about structure, and it definitely gets some, sometimes that word alone can sort of say somebody wanting me to work within a structure they create for. So thank you again for this wonderful session. It's been great to kind of think through some of these top-down, bottom-up approaches and the success. I think the idea that if we could perform at the top box level with that first slide you shared, the number of lives that would be saved is just phenomenal. I mean, just phenomenal. And we first, those have been around a long time. To err is human was 98,000 lives, right? Initially, and we know that there are more lives at risk with patient safety, preventable harm, and so we know that 100,000 is a big number if everybody could perform at that top box of performance against the best organizations. And so learning from some of those best organizations, like you shared with us today, some of that learning has been awesome. So it gives us something to shoot for. I think rounding is, if you haven't taken that message away, go back, think about how well your rounding's going and what you could do better with your rounding. So I think you gave us some really actionable things to take back, and we really appreciate the conversation today. And at this point, I'm going to turn it over to Riley to kind of close us out and take us home from here. So thanks everyone for coming, and thank you again, Daniel, for presenting.